Thanks for tuning in to the Medevac podcast, powered by the Robert Irvine Foundation, whose mission is to support and strengthen the physical and mental well-being of our nation's heroes and their families. I'm one of your hosts, David Reid.
And I'm your other host, Christian Meyers. Thank you very much for joining us on the Medevac podcast today. If you're new here, or if you're old here, you know what I'm going to say. There's a price for the show. You have to share it with a friend or family member if you get something out of today's episode. We've got some pretty interesting guests today, and we have a very interesting topic that we have not covered before. So you're going to get something out of today's episode.
Absolutely. Who's our guests?
Our guests today, two wonderful clinicians. We have Dr. Scharlene Gaudet, or Dr. G. That's her street name. And Dr. Michelle Eisenmann as well. They both they do transcranial magnetic stimulation and brain research. Am I correct there?
We do research. We also do just clinical therapies as well.
Okay.
TMS or transcranial magnetic stimulation is one of the therapies that we use.
Okay, fantastic. Well, thank you very much for joining us today. We're very excited to have you guys both on and to discuss this. It's a new topic for us, so we're very excited.
It's going to be, I'm sure, a very educational episode, which is going to be fantastic. Let's take it back a few years to how you got started, inspired in this world, and what that education looked like to build up to where you are today.
Actually, I got started after a head injury. So I ended up actually going through a TBI clinic, and that just kind of led into, well, I should be able to do this. So I went back to school so I could be able to do this.
Okay,
yeah, amazing.
So short and sweet.
Short and sweet. Well, that's easy. This is going to be an easy podcast today then, huh? No, I'm sure it's a little bit more complicated of a process than that, but we'll dive into the details of that a little bit later.
And I kind of got into this because my mom has a Charcot-Marie tooth. She has a peripheral neuropathy, and she has had many cancers. She's had a lot of neurological issues. My grandfather was an Army veteran, and he did have a TBI. He had an amputation as well.
Oh, wow.
And so neurological things in my family is very common.
Yeah.
So I always knew I wanted to go into neurology, and I happened to find this aspect of neurology.
So let's dive a little bit deeper into that. What are some of the effects that you saw from that really drove home that ability to want to help patients out?
I think that for both of them, mainly my mom, because I was in there so much for my grandfather, I saw the after effects of him. I just kind of got tired of her going 6-month visits just to check her for 5 minutes and say she's fine, but no one really focused on her quality of life. No one really asked her, how she's doing day to day. Oh, sorry. Should I speak louder?
You're totally fine.
1 second.
Perfect, right? Yeah, thank you.
No one really asked her how she was doing day to day. No one asked her about her nutrition, movement. I mean, nothing. And so it's almost like they were just waiting for her to get sick again.
Yeah.
So.
That's a constant thing that we happen to see, right? Kind of that medical system is keeping customers as opposed to practicing medicine. Right?
Solving the root causes.
Yeah.
Yeah. And it looks like you have something to say on that subject there.
We are on average probably the 7th doctor that most of the people have seen. It's been as many as 15 looking for help.
Yeah.
We hear, I went to a concussion specialist. They told me concussions, you can't fix them. Wherever you are at the end of 6 months is where you're going to be. And so the level of frustration from what we hear from people that come in, from our colleagues in the field, is a bit of a challenge.
Bit skewed.
Yeah.
Yes, it is.
Yeah, because you obviously understand that that's not the case.
Correct.
Right? Is that what you're saying?
Yeah.
So what do you tell those people that how does that conversation go when they're coming to their 7th, 8th doctor and you tell them, hey, everything that those guys just told you is wrong?
And you do. We say that, and we try to start off generally in a much nicer conversation.
Sure.
But there are days that you're going to catch where the conversation isn't nice. My level of frustration is on my face. It's in my words. I'm like, that's just a bunch of crap. Let's see what we can do. And so we do, right? We're going to look at you. We're going to talk to you, figure out what's going on with you. But you're going to fill out a lot of extensive paperwork before you come in, because I don't want you coming in if I don't think I can help you just by what I see. I need to make sure, depending on the medications you're on, there are times that your brain can't map.
Yeah.
You cannot get that neurogenesis that we were talking about earlier. You can't get it. if you're on certain medications. So I need to know that before you come in so we can, put a halt to it. So we're not wasting anyone's time or being another notch on somebody's I've been to 10 doctors kind of thing.
So there's medications that people are on that are causing neurodegeneration or just the inability to regenerate?
Both. Yeah.
Okay. And are those pretty common?
They are. Yeah.
Okay.
Especially when we're dealing with, certain psych meds, depending on the psych diagnoses.
Okay.
Pain medications have become more and more prevalent. Wow.
Nah, it's all right.
So
And
off-label use.
And reset. And say it again. Yeah. Someone, Jesus Christ.
What is happening? So some of them are the neuropsych medications. Some of them are pain medications. A lot of them are medications being off-labeled used, right? And so when you come in and we see this whole list of medications, one of the things we do is sit down and say, okay, I know what this medication is.
Yeah.
Tell me why you're on it.
Okay.
Because it may not be, it may not be for the reason that this medication is out. It may be, 4 reasons down
Sure.
that they have somebody on something.
Okay.
Yeah.
And so medications are a big challenge to work around.
I do want to kind of rewind it back a little bit. We're kind of like diving right into kind of triage, right?
Right.
Let's talk about the fundamentals of a concussion, like the traumatic brain injuries, what it is, what that definition in total is, and what you actually do, like with the treatments. I want to see the treatment process, right? And how's that look?
Well, one of the big challenges is, for years, people thought you had to lose consciousness to have a concussion. So the first thing we have conversations about is it doesn't have to be a loss of consciousness, right?
And microconcussions are a big thing that we talk about.
Huge. Exactly, right? Because they don't realize that sequela, that
Compounding as well.
Compounding injuries have made it to be so much of a larger issue.
Yeah.
And then there are several times where they don't realize that they started off with an actual traumatic injury, right? An explosion or such. And then the medications they were on and had a severe reaction to caused a secondary one. And then there was a loss of oxygen that say they did lose consciousness and stop breathing. So now we have 3 concussions in a period of 24 hours.
Wow. Yeah.
And none of that was put down on a chart. This wasn't, it was just a blast. It wasn't, they're treated so. And so first we have to determine how many are actually concussions.
Yeah.
Because oftentimes there's a lot more than they realized. And so once we make that determination, then we can go from there and start, looking at you going, okay, what else do you have? And more importantly, what are your goals? What do you want to get out of this, right? Can we help you with that? Is it somebody's labeled you as PTS when it's actually TBI, right? Or vice versa. So it's establishing what's actually going on with someone, and the other thing is to make sure they know that you're not crazy, right? Yeah. You're dealing with these things, and this is a true issue, despite how many people have said it's not a big deal, or at this point you just live with it, right?
Yeah, that is so true. So correct me if I'm wrong here, but a lot of the research, besides like we talk about the war machine and how it has advanced medical research quite a bit. But the microconcussion research was the NFL, right? Is that where you saw a lot of that new kind of information come out?
Actually, there's a systematic review out, I think it was like 2014, 2015, that is trying to kind of coin, we've talked about this, like concussions to be more diminished brain resilience syndrome. And they actually compare in the veteran community and in civilian community how the prevalence of mild traumatic brain injuries, which is the same thing as concussion, but yes, not such a veteran, am I? Okay. But
just tapping on the table, just got to keep that rhythm.
Yes. Anyways, so they do compare mild traumatic brain injuries, which is the equivalence of a concussion, to moderate and severe. And they talk about how the prevalence of it is so much higher. And we're actually, as a society, doing very good with moderate and severe, which is what everyone traditionally thinks about. You have to have this like very traumatic injury and land in a hospital, when you really don't. And they talk a lot about the reason for it being is because metabolically as people, we're not very sound. So we're already not eating the right things. We're surrounded by toxins, by pollutants. And so when you do experience a concussion, the ability for your brain to be resilient against it is a lot less.
That makes sense.
Yeah.
Which is why we see more now than we did, say, 25 years ago,
Okay.
right? Because we actually did have different sleep patterns, different lifestyle patterns,
Sure.
and a whole lot less pharmacology.
Yeah, that's increased dramatically, especially within the veteran military community. I mean, like we talk about pretty often, as you transition out, they typically give you your big bag of pills and, hey, here's your medications for the rest of your life. A lot of those have conflicting issues, and
Right.
yeah, they can oftentimes exacerbate some of those symptoms, right?
Yeah, another interesting one that we were just discussing, being here at this fabulous event, is the chemically induced, right?
Yes.
Chemically induced kind of traumatic brain injuries. And can you expound on that a little bit?
So there are a lot of ways to have a brain injury. We talked about the trauma part.
Yeah.
You can have a chemical brain injury. That can be from a medication that was prescribed that you had a reaction to, or something that wasn't prescribed that you had a reaction to.
Yeah.
You can have a hypoxic injury where you've lost oxygen for even seconds, right? You can have a vascular injury. The vascular injuries are things like your strokes, right? You can have a viral injury, brain injury, right? So there are so many ways, and that's where that compounding comes in that we talked about, is because there were so many things that happened and you didn't realize all of those added another layer to your injury. And so pharmacology is a huge one for creating injuries for people.
Yeah, there's Dr. Mark Gordon. I'm not sure if you're familiar with. Yeah, he does brain studies. One of the big things that I took away from him was a lot of people with TBI who are taking things like finasteride, which is very commonly prescribed to men. It increases brain inflammation to a point where it exacerbates those symptoms, and it leads to.
But you could keep your hair.
Yeah, you can try to keep your hair. Yeah, but it's something that a lot of men that we're dealing with, and there was no rhyme or reason or explanation to it. And I listened to a couple of his talks on it, and I was on finasteride at the time, trying to keep myself from going bald, but I was experiencing exacerbated symptoms while I was taking it, and I did not realize that it was directly correlated to that. Right. And as soon as I stopped, this was during my transition out of the military, so I was dealing with TBI symptoms, what I thought was PTSD symptoms at the time, but it was TBI, taking finasteride, and as soon as I got off of it, maybe 5 to 6 weeks after, I noticed a sharp decline in those symptoms.
That's beautiful.
I'm like, well, I should try to avoid this in the future then.
Yeah. And those are the things that, unless, you don't want to be the fanatical person that looks up every drug. Oh my gosh, these are the side effects.
Yeah.
But you kind of have to be. You really do need to know what some of that is.
Yeah.
Because if you're already dealing with those, I mean, some of the biggest ones we see is they'll put somebody on medications and it lowers their blood pressure.
Yeah.
Where they were already hypotensive, right? They already had low blood pressure. So now the biggest challenge that we face is they're going to faint, fall, and get another brain injury.
Yeah.
So now we're dealing with that, right? Because it's a medication-induced issue.
And something as simple as like Claritin or like an antihistamine that can actually be an anticholinergic drug. No, it's advised. Some people actually advise to take that daily as a way to get against, having allergies.
Yeah.
But there's actually significant research to point that long-term use can create dementias. So, like she said, it's more so understanding the mechanism and really having a why. Why are you taking this? What's the purpose? And can you measure the outcome?
Sure. And you're talking about antihistamines. I know there's different classes, right? And they're starting to get away from Benadryl and Zyrtec, right? Those are like the big ones. They're starting to push off and replace them with more modern antihistamines, or are they using more natural modalities?
Well, there are natural modalities,
Yeah.
but they are pushing them to other medications because they see the brain atrophy and some of the neurodegeneration that it's causing right now.
So interesting.
Pretty interesting, too, that these brain injuries could lead to, like, different system responses as well, right? Your sense of smell, like these kind of things as well. So what are some of the kind of common things that you see, some of the most bizarre things you see? It's just a fun question I have to ask.
I think that's a fun question.
Go ahead.
Well, for us, it makes sense.
Yeah.
Because we know function drives, like the brain drives all these functions and it has these things. I think a big one is like an inability to read or comprehend what you're reading. Like I have a really hard time reading. And people attribute that a lot to IQ, which a lot of the time is that you can't actually look at a target or follow a target or skip from target to target because you've had a concussion or head injury. So when I say like, oh, in sports, do you remember how you got a concussion, you got to the sidelines, and they're like, can you follow this? Well, everyone sees that and they understand that part, right? And they're like, oh yeah, that makes sense. I'm like, well, that's why we have to measure your eye movements, and that's why you have a hard time reading. They're like, light bulb moment.
Yeah.
So I'm sure you have a few.
Well, and just to expand on that a bit, the metabolic capacity. So your body has an ability to make energy, right? And if you're a person that reads and 15 minutes into it, you're falling asleep, there's a problem. That's not normal.
I'm the opposite. Like, it keeps me up reading.
And so that is what we strive for so many people, because for the most part, they're really going to be about 15 minutes and they're falling asleep because it's so much energy that it takes to read, comprehend, understand, process, all of it.
Brain bites.
You got it. And they don't have it.
And, you know, we talk about that too with, and we just mentioned this as well, is like doing multiple podcasts as well. Talking, engaging, listening.
Yes.
Uses brain bites.
Huge.
Yeah.
Yeah. I mean, I'm sweating right now just talking to you.
We can talk about some of your autonomic issues.
Yeah.
Well, that's
Meyers.
because as someone who's lost their leg, I don't have a proper, circulatory system, but you know all that stuff.
Please tell us more.
But that's why I reach out to these nonprofits and ask them to build me pools.
Oh.
No, it's funny, as I do work at a nonprofit as well, and you'd be surprised at the level of outreach that you get.
No, I wouldn't.
And entitlement as well. I'm sure you get that actually quite often.
We do.
And let's talk about how it affects our temperament.
Most of us realize that we have emotions, right? And emotions are very normal. But what they don't realize is the ability to have an emotion and the ability to gate an emotion are in two different areas of the brain.
Neuropathways.
You got it. And they have to be able to communicate. Yeah. And when they are not communicating, you are in fact having emotions that you should be having. You just aren't regulating them to the situation that you're in.
Sounds a lot like post-traumatic stress.
Can you believe?
Oh my goodness.
And so there are a few things between TBI and PTS that are overlapping, right? But there's only about 5 of them. But that gave the VA enough to say it's the same condition.
Of course.
Right? So they put it together when it's not, right? If you work on someone's TBI, will their PTS improve? Yeah, small amount, because there's a few overlapping symptoms. If you work on PTS, will their TBI improve? A small amount, because of the same overlapping systems. But fixing a TBI will not fix PTS, and fixing PTS absolutely will not fix a TBI.
Sure.
They need to be addressed separately because they are separate conditions. Yeah. Right?
Interesting topic. We do talk about this too, and I like to look at it as like post-traumatic stress, shell shock, right?
Right.
After Vietnam, we really start diving into the research on it, and now it becomes the focal point in the beginning stages, and now we're really seeing the TBI research being like, oh, this is actually might be a little crazier, right?
Absolutely.
Yeah.
So the TBIs actually set you up for PTS because the brain isn't functioning the way it should.
Sure.
And so you no longer can filter and process the information that you're dealing with. So it is not uncommon for people to have been diagnosed through the VA, for them to have been diagnosed with PTS and then not have a TBI rating, although they talk about their hard landings, right?
Yeah.
My helicopter landed hard and rolled a few times, right?
Used a piece of equipment that I was only supposed to use a few times, but
Yeah.
Too.
The mortar
Used it for
and
years.
stuff rounds that you're only supposed to fire 6 a day, and you're ending up firing 23, right? That overpressure.
and I got nauseous afterwards, but it was fine.
Yeah.
It was fine. My ears are only bleeding, but
Yeah, exactly. We used to sit in the back of the helicopter. We'd have 50 cals on the side, but if you're instructing, the barrel would be right in front of your face while somebody's shooting, and you could feel it inside of your teeth. Every
Dear God.
Yeah.
micro concussions, hundreds and hundreds at a time, just boom, 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 boom,
Yeah.
right in the head. Yeah.
oh yeah.
Which you could heal if given the right circumstance.
Sure.
However, it wasn't.
Yes, exactly. Yeah, and they don't necessarily in the military, at least on active duty, they're not extending that, right? If you're raising your hand for some of those issues, it's usually they're showing you the door,
Right.
And you're kind of left to your own devices because, you guys are kind of at the leading forefront of this. What are you seeing the VA implement as far as addressing the issues, discerning between the two, right? PTSD and TBI. First of all, discerning between the two, but addressing them individually. Are we seeing strides? Are we seeing progress at all? Or is it kind of a slow trickle right now?
We're not seeing any strides with it.
It's a zero.
Because they're still rating it together.
Yeah.
You don't actually have to address it separately if it's together. And so we don't see a lot of it, which is unfortunate.
Not a lot of cohesiveness in between practitioners.
Sure.
Because you do have different practitioners, and different practitioners practice differently. And so some practitioners discount it. Some practitioners may acknowledge it, but don't go further into it.
Hence 7 doctors.
Yeah.
7 doctors before they typically come to a specialized program. I mean, going back to temperament as well is you see, the way a lot of military members outlet themselves, and they use that kind of anger-driven response. So is that something that you're seeing quite often? Is that just high stress, reactive mode constantly turned up to 100?
Yeah. Well, and to be fair, you've lived like that for so many years. It oftentimes scares people to all of a sudden not have that.
Yeah.
So they'll have a day or two of just that down, and then there's fear that comes in. And again, the frontal lobe's not there to gate that fear.
Yeah.
So then they have to do something to put them back into what they feel is normal. It's not normal, but it's normal for them, right? So they do some activity that brings it all back up. And even if that's getting mad, right? They get that back where they need it to be because they're used to that cortisol level being high, and they're used to running really up here. So if you drop them down, there's fear associated with it.
Yeah, I mean, it is something that we talk about, at our foundation is these invisible wounds, right? And, I have a very physical injury, so people, if I had a traumatic brain injury, they assume, he's just a crazy veteran, he's fine. But, when you don't have, you know what I'm talking about.
I
That's
do.
why you get it all the time. But, when you don't have those physical injuries prevalent, you all of a sudden start roping them into just a mental health nutcase, right? And that's not the case as well. So you have, these people who don't want to open up about it as well. And then they get that anger-driven response. So I guess what's the workaround that we find, when we have that patient in the room saying, man, it's been 7 times, no one's helping me, you're getting frustrated, you're feeling defeated, you don't want to admit it, right? Because it's embarrassing. How do you fight that?
Well, part of it is we get to see it on the paperwork. We already know it before you come in.
Yeah.
So the questions we ask are because we already know the answers. I need to see if you're willing to have that conversation with me yet. Okay?
Yeah.
And sometimes you're not. Sometimes it takes you 2 days. Sometimes it takes you 3 days. But generally, by the 3rd day, you're ready to have that conversation. Hey, doc, did I tell you this? No, you didn't tell me that. We call them the OBTWs. Oh, by the way, doc.
Oh, by the way.
Oh, by the way. And I'm like, no, we didn't talk about that. Let's talk about it, right? And so by the end of the program, you already know that I knew, but you waited to tell me, and that's okay, right? We have to build that relationship because you've been to several docs and you don't have that trust that anybody's going to be able to. So by the 2nd day, when you're starting to feel better, and by the 3rd day, where you come in with that look on your face, there's no way I could feel better on day 3. What's going on, right? That's when you're ready to start talking. You want to know some. So that's one of the things we have to deal with. So we ask on that initial exam, what are the 2 emotions, because I know there are, right, at least, what are the 2 emotions that you feel like you bounce back and forth between? And so oftentimes it's apathy and anger, or anger and sadness, or, anger is almost always in there, though.
Yeah.
Okay?
Typical response.
I feel like we do a pretty good job at relating, even if they're not comfortable talking about it. Like when we have their diagnostics, we do a pretty good job at relating it back to just brain health in general. Because a good point to make too, because I feel like, a lot of social media people are posting about these things and dysautonomia and concussion, and they're like, oh my God, and now I have this, and now I have that, and now I have this, and it's like label.
WebMD docs.
Oh, yeah.
Yeah, it's all related. We're talking about functional systems, and if one part of a system is not doing well, the other part of the system isn't doing well. And what makes more sense, that you're going to go throughout your whole life without ever bonking your head or having a perfect brain, or that throughout your journey, you're going to have times in which you're going to have optimal brain function, and you're going to have times you're going to have suboptimal brain function.
Yeah.
So I think that when they talk to us about the issues they have, and we relate to them, this is how it relates to your daily life, and we show them, and this are the functional issues that you're having and how it relates to that, it takes some of that fear out, because it's like, oh, I'm not like an odd case. Like, this is just my brain health, and I just should take care of it.
I think that's something that a lot of people miss, especially when addressing doctors. And I'm sure I don't want to speak for you, but I'm sure you might agree with this. Is people will come to you, and if they have a physical symptom or a physical issue, they'll tell you straight up, my leg's broken, my knee hurts. If they're having mental health issues, they're more reluctant to bring that up. Hey, I'm having depressive episodes. Hey, I'm having manic episodes. Whatever it is, I think a lot of people, and I'm just applying this, I think a lot of people relate mental health with a broken self, right? A lot of people think that their thoughts are themselves, or their brain is who they are. They don't realize that it could still be a physical symptom that is causing these shifts in your mood swings or your temperament. Is that something that, am I right there?
Yeah, we see it.
So.
Yeah, absolutely.
Yeah.
That's that whole "I feel crazy."
Yeah,
you know,
of course.
and that's the statement we hear the most. Is I want to say thanks for letting me know I'm not crazy.
Yeah.
And if we can show you what part of the brain affects what, right? If I can show all of that to you, half of what you get in the clinic is education. You're educated about your brain. So when something is starting to happen, right, that emotionality is coming up, you have a moment to step back and say, okay, I know why this is going on. Whereas before there was fear, because now you thought something was crazy. So you were being weak or whatever it was, right?
Yeah.
And so now you're like, no, I'm educated. They actually educated me on this, and I know what's going on. So I either, one, find somebody to help, or two, I do some of the things that we talked about when we were in clinic, right? So there are tools. You're going to go away with education and tools to be able to move forward with this.
Yeah.
Because you can't fix everything in a 2-week time frame,
Sure.
but I can get you on the road to things, right? I can help you get to the next step.
Yeah. It's not a fix it, right? It's not
It's not a one shot, right?
It's not a one shot fix.
Right.
Yeah.
Yep.
And, the military at that aspect is even more, skeptical to approach their leadership for this as well. We see this across the board because you would get fired.
Right.
Especially, we had a guest on, his name's Keegan, AKA Smurf pilot, who ejected out of fastest naval ejection in history, survivable, right? And he, how can you go to your leadership and say, hey, I'm kind of struggling with this right now, and they just revoke your ability to fly.
Absolutely.
Right? So now these people, compounding effects over years and years of service. So I just want you to elaborate on the fact that this is not good for you. And that's my terminology for it. Yeah. But isn't that true? It's like now we have 20 years of service that we haven't addressed because our leadership wasn't educated enough.
Well, and you look at somebody like Keegan, and then you say, okay, the military's put this much time, energy, and money into him, and if they're going to cut him loose, what are they going to do to me, right? Yeah. And so that is where that fear comes in, and that is where the compounding of 20 years has come in. Yeah. And had this been handled, one of the things that would be our goal is to be able to get people when these happen in service, right? Yeah. But at the very least during that transition period. So you're already having a hard time transitioning from a very rigid world, right, into what we call the civilian world.
Yeah, the free world.
There it is. I don't know that that's it, but we're going to call it the civilian world.
Check.
And so there's that huge transition to begin with. And if you do not have a fully working brain to its optimal levels, and you're having to deal with what is lesser to you in this world, it creates a lot of not just animosity, but a lot of anxiety, sleepless nights. You don't understand this world, and your brain isn't helping you. Yeah. Right.
And that is also training you as well. I mean, that anxiety, that stress, it's all
plasticity.
Good. Yeah.
So
that's right.
essentially, no, it's not good to keep this stuff quiet. You have to get help because your brain doesn't understand good or bad. It just understands do.
Yeah, and the brain is lazy as shit as well. It's just like shortcuts galore. So then you're just let's shut down that highway. Let's shut down this one. Let's that's how I brush my teeth, and that's the only way I do it, right?
If it had the energy, I think it would take less shortcuts.
Yeah.
But most of us do not have the metabolic capacity to do the things we need to do. So it goes into survival mode, and it's going to take point A to point B, and it's not taking the long way around.
So let's talk about preventative things that you could do along the way that might prevent this, might prevent you from needing to go to your leadership and saying, I can't fly anymore.
Something we would love
Yes, tell us.
is if people would really focus on their metabolic health. Do you really need that Pepsi? Like, could you really not substitute it for a better drink? Like, you make that one change a day, and I know that
Pepsi.
There it is.
That's
it.
Like, please no. Please
Lord.
don't.
And what she means by Pepsi is Monster, right?
Yeah.
The energy drinks that are
Perfect.
really actually the neurodegenerative stuff that we were talking about. There's one of it, right? I mean, when you're dealing with these energy drinks, it's giving you some energy, but if you look at the rest of the ingredients in there, it actually is neurodegenerative. So you're just breaking it down one drink at a time.
So,
Right.
metabolic health, cutting out
metabolic
processed
health,
sugars.
sleep hygiene,
Yeah.
something simple.
Sure.
Like, you may not have control over a lot, but you really do have control over what you consume.
Yeah.
And how you prepare yourself for nighttime.
Absolutely.
Are you
Yeah.
putting yourself in a deficit?
Great segue into alcohol.
There you go.
The original nighttime sleep.
Yeah, right.
Boy.
Grandpa's cough medicine.
So alcohol really emphasizes these effects as well.
So one of the challenges that most people don't realize with alcohol, so you use it to go to sleep. And in fact, it does help some people at certain quantities sleep, right?
Sure.
It gets them to sleep. But what they don't realize is because of the increased amount of blood sugar, right? Or sugar that's in it, you spike your blood sugar, which is where you get that anxiety and the heart rate starts to raise. And then it drops through the floor. Well, when your blood sugar drops at night, your brain is all about survival, okay?
Yeah.
It could care less if you have legs, but it surely wants to survive, right? And so what is it going to do? It's going to wake you up. So now you're not getting that restful sleep. You're going to wake up because if you don't, the brain is saying, hey, listen, I'm going to go into a diabetic coma. You got to give me some, right?
Yeah.
So it wakes you up. Because when your brain wakes you up, it elevates cortisol. That's the hormone for it, right? Cortisol always, without exception, elevates blood sugar. So how do we get your blood sugar up? We wake you up.
Yeah.
And then what do? We tell you to go pee. Why do we tell you to go pee? Because I need the insulin to come up, right? And you have to have insulin in the muscles to get to the bathroom.
Yeah.
This is how we wake you up, right? So you may go in there and have 3 drops come out and go, seriously, I got it for this.
Yeah.
And then you go lay back down, but your blood sugar's up. It's not down, right?
Yeah.
So you fall back to sleep and it goes down again. And your brain wakes you up and says, go to the bathroom again, right? So this is where you get this up and down thing all night. So it sounds good because it turns your brain down so you're not having that perseverative thought, whatever's in your head, and you get to sleep, but it will not keep you asleep. And long term, it's very destructive.
You also don't get restorative sleep. So something that's also very popular right now is heart rate variability.
Yes, yeah.
So you'll see how a lot of brands like Whoop and Aura are touting themselves to X amount of people with Whoop and Aura have quit alcohol because they actually can see the trending patterns of
It's amazing.
not getting sleep.
Yeah.
Yeah. But it's a neurotoxin.
Yeah, true.
And I could see where the correlation between seeing if it's PTS and TBI comes into place too, right? I can't sleep because, right, I'm going through that post-traumatic stress, those symptoms there. So do you kind of see the commonality there of like, you see a patient really believing that it's PTS and then all of a sudden, boy, we treat it with this program
And they
lo and behold.
So sleep is, I think, the thing we hear about the most and the soonest.
Yeah.
Generally, we've changed someone's sleep within about 48 hours of coming into the clinic.
Interesting.
Okay, and I would say that's a better part of patients.
I should come see you.
I think we should talk about that.
Yeah, we should hang out.
There she is.
She did say.
Without sleep, nothing else works.
Yeah.
I mean, that's the bottom line. So we can do the best work in the clinic, but if I can't get you to sleep,
Yeah.
it's the basic foundation for your brain to heal.
Yeah.
Because your brain only heals when you sleep. It does not heal during the day.
Sure.
Right? Or when you're awake.
So we've talked about prescriptions, we've talked about temperament, alcohol. let's dive into memory and recall.
Let's do it.
Let's do it. So, you experience these types of brain injuries, and I went through my experience when I stepped on an IED, and at first, like, it was very difficult for me to memorize what was in front of me.
So now we're talking about a separate area of the brain, right? We're talking about that.
We switched.
We did, talking about that hippocampal area is over here. So
You weren't expecting this level of podcast where you thought we were going to be snapping jokes and being bros.
Chugging beers.
So we're going to do that later, you said? Okay, good.
Yeah.
So memory is very dependent on sleep first, right? Memory is also dependent on multiple areas. So we have primaries and we have secondary parts to memory, and there's a bridge that has to connect those two. And so when a memory comes in, it has to go into both areas, send a message back and forth going, I got it, you got it, okay, lock it in, so now it's locked.
Left and right.
Okay, you got it.
Corpus callosum, you got it.
Yes. And so once we have that, then we know that's in. So then how do we recall that? Well, there are a lot of different ways to do it, right? And unfortunately, sometimes memories get stuck. So my best example is a Rolodex, right? You take this Rolodex card and say it was the IED, right? So you have the term IED over here, and then everything that happened at that day, the sight, the smell, the feel, the everything is on that card. And so then it's filed in your brain. Even if it's inappropriately filed, it's still filed. And so when one of those things happen, it pulls that card and all of that comes back again, right? Now, it's inappropriate that it's filed that way, but that is how your brain filed it. And so, there are things that you can do to dissociate those, right? Pull it apart, refile it, get your brain to say, hey, I'm not going to forget about this, but I'm not going to have all of this as a trigger anymore. That's an event.
Responses.
Absolutely. Yeah. And so in the clinic, we use smells a lot to lock a memory, and we use smells to pull a memory, right?
Yeah.
And so this is something we talk to students about too. If you want better test scores, these are some of the ways to do it.
Yeah,
and we both use this.
I mean, what did they, I forget the terminology for this, but this is, situationally, right? When we chew gum, when we study, we chew gum when we take the exam.
Yep. So that does a couple of things, though. Chewing gum puts you in a rest and digest state. So that's vagal tone.
Parasympathetic.
You got it. So we're just really going into your parasympathetic state, getting you all rested out. And then if you're chewing the same gum with the same flavor, now that's where the pulling of the memory comes in. But both of them put you into a very restful state.
Yeah.
What do tests do to us? Right?
Stress us out.
They stress us out. They cause a very sympathetic response, which means that cortisol is coming up, and your brain doesn't need to answer test questions when cortisol is ramping. It needs to get the hell out, right? That's what it's supposed to be doing.
Fight or flight.
Fight or flight.
Right.
And so the gum is going to help you keep all of that. So yeah, you can use taste, you can use smell. Smell is the one we use the most in the clinic, though.
Interesting.
Memory does tend to get better. I would say the only things we've seen is if we have a person that their memory wasn't 100%, it's usually because they have to, then we do a referral. Hey, is there something that you haven't processed that you need to go work out with someone else?
Yeah.
Because it's kind of like a box of chocolates. So if you're going to suppress, and a lot of the times like, I lose my keys, my wallet. Well, if you're going to be good at suppressing your memories for something big, your brain doesn't care. It's just going to suppress that too. But also different areas of the brain are correlated with different memories. Working memory, long-term memory, short-term memory, procedural memory. So the cerebellum, which is a hugely chemically sensitive area of the brain, which is fine motor coordination, has a lot to do with...
Hold off.
Okay.
No worries. We'll edit that in post, so it's good. So I want you to just kind of restart.
Go back into character.
No. You could just
You're
start
totally
where
fine,
you
Michelle.
left off. That's all.
Yeah, Michelle, can you move your mic kind of in between you and Dave? The other way.
Oh, I'm sorry.
Yeah, just shift it that way. It's going to be really hard to edit. Just move it to the right a little bit. Just, face it to the right a little bit more. The mic.
Yeah.
Other direction. There you go, like that. Just so when you're facing Dave.
Yeah,
and
sorry, it's
facing
hard
us,
because the mic's over
I know.
here and you're over here, so I have
It's okay. Don't worry about it at all.
No, don't worry about
Just
it
playing with
too.
the dome.
And then you're kind
Totally
of
fine.
speaking because your mic will pick
Yeah.
up on hers. So
Yeah.
it's weird. It's weird,
It's just
but
little
it's easy.
things.
That's why we have editing, and it's great. That's why we use 2 cameras.
Yeah, totally fine.
Because they're going to just awkwardly look at us for 30 seconds. No.
Got it.
Okay, so right where you left off. You ready?
Yeah. So basically, the cerebellum is a very chemically sensitive area of the brain, but it is tied with some cognition and memory. So something we can do too is with diagnostics. Hey, it looks like this area of the brain's not doing very well. Cognitively, we see how that can affect. Physically, we see how that can affect. And so that's another way that we work with memory too.
Yeah, movement.
It's not always emotional.
Right.
It can be physiological.
Yeah. So getting people to move oftentimes will help. And we've all done this, right? You pick up your phone and you stand up and you start walking around to have a conversation. Makes you
time.
think better, right?
Yeah.
That movement is helping.
Yeah.
And so we can use that.
Asymmetrical training as well, right? Really helps with this. Is, if you're going through a brain injury, pick up the guitar and learn how to play it,
Absolutely.
right? So what are some challenges there that you maybe give patients along the way?
So take something that you do every day and do it new, right? Do you brush your teeth with your right hand? Great. Brush them with your left.
Yeah, I do that
right?
all the time. I'm just like, I do.
And don't do this in,
I'm a weirdo though. Yeah.
don't do it in public, but
I'm
you
like,
know,
I'm
if you
training
eat
my
with your
brain.
Training my brain.
please do that in the mirror. I want you to say that in the mirror when you're doing So we give them tasks that they do daily. We just
Yeah.
make them do it in a different way.
Okay.
Your brain it needs, especially for dopamine, right? It needs you to do something new.
Yeah.
And so learning music, learning a new language. One of the papers we were reading recently talked about, which languages are primarily left brain and which languages are right brained. And if you're,
So interesting.
and if you're primary one side, then, start working on the other one.
Yeah.
And so,
Golly, the MRI is an incredible piece of equipment, isn't it?
yeah.
Yeah.
Right.
I
I'd
do
just like
want to
be able-
mention something. We actually had someone, this is I think y'all are going to find this interesting. You know who I'm talking about. We had someone that had a form of an aphasia, and
Okay.
so had a very difficult time with communication.
Yeah.
Did not know that this individual had a second language, which was Spanish. And so when we spoke Spanish, because I speak Spanish,
Yeah.
I was very fluent. And so one of the ways that we helped him was we found these papers that talked about the different networks that are involved in Spanish and English.
Yeah.
And so through his Spanish, we started then converting it to English to help with that
that's
aphasia on the English side.
so interesting.
So that just jogged my brain on that.
Yeah, I was going to mention probably Germanic versus Latin-based languages,
Right.
right?
Yes,
completely.
That's totally right versus left. You have
Yeah.
very structured versus very flowy and artsy, right?
Yeah.
The love language.
Yeah, exactly, exactly. That's very interesting.
Very interesting too. And I know this might be like off on a little bit of a tangent, but when we talk about these, people retiring, right? And all of a sudden they stop what they're doing,
Right.
right? And I just have to hear it, like dive in a little bit about that.
And they die within the year.
Yeah.
And they die. Yeah. Or, their significant other as well, right? We stop challenging ourselves and we stop learning. And I think
Right.
that's the biggest thing. We stop exposing ourselves to new things. So our neural pathways start shutting down. And that's why we have black spaces in our head during Alzheimer's and all this stuff.
Right. Well, it has, in my opinion, it has more to do with purpose. So you've had a purpose every day for your life, right? You've gotten up, you've taken care of your kids, you've gone to work, you've done all of these things, and now you're in retirement. And I actually had one of the neurologists we work with, he said to me, he was going to some conference. I was like, hey, what are you doing? And he's like, I'm going to a woodworking conference. And I'm like, okay. He says, I'm preparing for retirement. I was like, all right, tell me a little more about that. And that was where the conversation kind of opened up.
Yeah.
He said, this is the reason these things happen to people. And I said, well, I've read the papers. I understand that part of it, And he said, but purpose is a big deal. And so I'm finding my new purpose before I retire, so it'll be a smooth transition for me, right?
That's a smart person.
And so that is a conversation we've had with, I don't even know how many people at this point, because, even family members, right? You need to have something to move into, right? Having that dead space is just that. It dies in the brain too.
Yeah.
So you need to figure out something that brings you joy,
Yeah.
right? If you worked at a business all your life and you didn't enjoy it, how about you find something now that does bring you joy,
Absolutely.
right? In your time. So you have to keep things activated, right? Activation is 100%. That's getting up and walking when you're on the phone, right? You need movement, you need activation, but more importantly, you need purpose. Got to get out of the bed for something.
The brain's hard. Oh boy, right? Isn't the brain hard? It's like all these tips and tricks, right? And it's funny enough, is people retire out of the military at a young age too.
Very.
Some people decide to just stay sedentary, like off to the woods and stuff. Pick up a guitar, pick up some sort of hobby where you're challenging that left and right, and you got to stay active as well. And that's a big thing too. So purpose is, oh my God, it's a subject that we touch on all the time, especially when you're abruptly stopping your career in the military.
Especially when it wasn't your choice.
Yeah.
Oh yeah.
Absolutely.
Yeah. And that happens in the civilian world too, but it definitely happens in the military, right?
Yeah.
And there's a little, for you guys, it's a little different, right? Because you gave all of this, right? You signed the paper and you made the decision, and somebody else cut that short for you.
Yeah.
And so there's a level of anger that comes into that, right?
Sure.
Betrayal, there's fear, there's a lot of stuff that we see when you guys are in that transition that wasn't your choice for transition.
Yeah.
So,
Yeah. Before we get too far away and run out of time, I want to talk about the modalities that you guys offer, and specifically about TMS. So we've not really discussed transcranial magnetic stimulation on the show before, so I'm very interested in how exactly that process goes and what it's actually changing within the brain.
you want to start?
Sure. It's a magnet.
It's a big old magnet? Yeah.
Not to be, I say that just
love
because
that.
a lot of people confuse it with electroconvulsive therapy, and that is not to be confused.
Not the same.
Not the same.
It just changes polarity in the cell, and it activates a cell. So very different. It's meant to activate, not kill cells. But basically, it's a copper coil that goes into a focal point. We have something called a CZ cap that allows us to kind of take appropriate measurements of where an area of the brain should be located in your head. The magnet is then placed on your head. It actually has to make contact, so you will feel contact. And then from there, we put our parameters in, depending on what you're coming in for. We have different parameters for people with strokes, concussion. Our focus is neurorehabilitation and functional improvement.
Okay.
We have had movement disorders as well that we help with a lot. And our goal is either to activate an area that could be for inhibition. So if you activate the frontal lobe, it's going to inhibit other things or other, the aggression. Maybe some of the things can help with that.
Okay.
So a lot of the times we utilize TMS as a sandwiched therapy at the beginning and at the end of our therapy. And I think where we differ and are pretty unique is that we don't just do a passive therapy with you, because TMS is a passive therapy. It doesn't require you to do an action, but we follow that up with actual action. So if we're going to stimulate your frontal lobe with a TMS, afterwards we're going to require you to do active activation of the frontal lobe.
Got it. Interesting.
And TMS is actually not a new therapy. It's actually been around since 1984. So the challenge with it is, however, it has been in psych offices since 1984. And I don't think they had a very good appreciation for what it does, how it does, and all the things that it can do.
Yeah.
And so it just kind of sat dormant for a long time. It's a VA-approved device, right? They are in your VAs. I know because I've been there to visit, okay?
Yeah.
Most of them that Donna and I have seen as we visit are covered and have some dust on them because they're not being utilized, because people don't actually know what or how, which just boggles our minds, right? Because it is an incredible piece of equipment and therapy.
We have a whole nother podcast on Big Pharma. So,
You know what the awesome thing is? If you're on Big Pharma, you can use it. If you're not on Pharma, you can use it. It helps either way. And so that's the most awesome part of that.
that is actually a huge, huge part of it.
Yeah.
Yeah.
So you don't, the only time we have to turn someone away from using it is if they have metal. You can't have metal more than 18 millimeters at the focal point.
Okay.
And so, a plate, obviously.
in your head.
Shrapnel, as long as it's below the eye, we can do it, right?
Okay.
But if it's up, we
So
can't.
neck down, you're good.
Completely. Yeah. So spinal stimulators, any of it, we're totally good. Good
Fillings?
with fillings are fine.
Okay.
Right.
Okay.
Because we're more than 18 millimeters, because we're on the frontal lobe. We're up here, so we're more than 18 from the focal point.
Okay.
Companies do a good job at telling you, too, what are the contraindications. There are not very many.
Yeah. So it is amazing. And they're using it bundling with so many other things now. Like we bundle it with a lot of neurotherapy. There are people, on the psych side bundling it with ketamine for depression. There are people, so they're bundling it with a lot of things because if you activate a certain area, right, we're activating that frontal lobe and then we take you into neurotherapy and just get after it in there, then we're really upregulating that. If you're in the psych and they're trying to build a new pathway in that frontal lobe so we can start to inhibit some of that aggression and stuff, they can do that and then partner it with some sort of pharmaceutical that can help neurogenesis. So you activate it, give them the pharmaceutical that starts neurogenesis, and now we're building in the area that we specifically want, right?
Kind of like exosomes, like you drive the therapy where you want it to go.
Yeah.
Okay.
Blood flow, right?
Yeah, they're using it with stem cell and exosomes and things
Very
like that.
interesting. So you're able to target very, very specific areas.
Very specific.
Yeah.
Yeah.
Wow. That's incredible. So my last and final question before I just bore you guys to death all day, is how does it wrap in? How does it tie into this event that we're in today? How do you connect the dots there, and what brings you out?
Well, we work with a lot of nonprofits. And so Texas Valor Project, being a nonprofit, decided that they wanted to get into the business of helping other veterans. And so they started to put on this event so that they could fundraise for the other nonprofits in the area because they had different ideas on what healthcare was than what they were receiving at their VA hospitals. So they came through, and one of the veterans came through the clinic, started to talk about it, and that small group, and the word of mouth just spread. And so the next thing we knew, those guys were coming in with Defenders of Freedom and Coast to Coast, and then Texas Valor, and they're all coming in, hey, we want to see what you guys are doing, right? And so everybody did the little test. I'm going to send one guy through. Let's see how it does, right? And then they sent someone through, and there was improvement. And they said, hey, I think we can get behind this. I think we want to do some fundraising. We want to help people with some non-traditional type therapies since the traditional stuff is medication and they're not getting anywhere with it.
Fantastic. That is fantastic. So where can we find y'all?
Top Hill, Texas.
So we're on Resiliency Brain Health or Resiliency BH for brainhealth.com.
Okay.
Amazing. So we could just reach out. And
So whether it's social media or just online, you can reach out if you have any questions.
Beautiful. Well, we appreciate the amazing work that y'all are doing.
We appreciate you guys.
We can't wait to go through the program ourselves.
I think you have to.
Or at least come by and
Look
visit,
at the face.
before you have that.
She asked us. There she is.
Yeah. The Donna.
The Donna.
The Donna. Yeah. Yeah. Capital D.
She got a shout out. There she is.
Yeah.
Well, thanks so much again for
Absolutely.
joining the show. What a wonderful conversation. Highly educational, like we predicted. So
Yeah, thank you very much for your time. You said resiliencybh.com.
.com.
Head on over to resiliencybh.com. Check it out. I'm sure they've got an abundant amount of resources, and you can reach out to them directly there if you're interested in partaking or learning a little bit more. And as always, interact with the video somehow, like, share. Send this to somebody who they might find this helpful. As always, thank you very much for watching the Medevac podcast. We'll see you next time.
until next time, bye.